Hey Jethro,
Good morning. How are you?
I'm good. So I went ahead and made you the host, and it is already recording. So anything that pops up asking you to authorize recording, say no. Like that. I think you should have just gotten something.
I did. I did.
So decline that, and then you can get started whenever you want, depending on how many people show up. But I'm gonna leave you to it, okay?
All right. Sounds good.
Thanks so much for doing this.
Yeah. Thanks. I appreciate your help.
Have a good one. Bye.
Thanks.
Jethro, how you doing?
I'm good, Jeff. How are you?
There looks like there was a change up on the link.
Yeah, I was searching for the link and I didn't have it, and then Summer
Yeah,
sent it out, I think. So,
one I had on my calendar was not working, and I saw the one from Summer and clicked on it. So I don't know if too many people are going to make it. It's kind of a last minute change.
well, you and Carolyn are we're all set.
Yeah, I mean Carolyn's here, so you and I can take a vacation.
Yes, you too. The link worked on my calendar.
It did, huh?
Carolyn, I was talking with Sarah the other day, and she was telling me about you guys having 3 TPE cases in one day.
Um,
I don't know how far back that was. Sarah
that
Crane.
might have been a couple weeks ago. We had two. We set up our amicus, and we like ran back to back a couple. It was a couple weeks ago.
Hmm.
Yeah. We Jeff Barnes, just so you know, the we treated a phenobarb dog Wednesday.
Yeah, I saw the little guy skipping down the hall. Looked
Dog
pretty
went home yesterday.
nice.
Unconscious Wednesday morning, went home Thursday.
Very nice.
Yeah.
What's was that a one single treatment prolonged?
Single treatment. Actually, we cut the session a little bit short. He we did we did carbon in series with our IHD. And then we did carbon in series with the IHD. We were taking bets as to when he would wake up. Emmanuel won, but she cheated. She came in, she said 45 minutes, and I said it's going to be a little over an hour, but she came in at 47 minutes and whistled really loudly in his face, and he woke up. So I feel like she cheated a little bit. Um, but he woke up, and so we ended up we were going to do we wanted to do 2 hours past when he woke up, a minimum of 2 hours past when he woke up. But we ended up like doing 3 hours and 40 minutes, and he did great. His starting phenobarb level was 62.2 micrograms per mil, and his ending directly post session was 15.
Amazing.
Yeah, 76% reduction.
Were you able to yeah, tease out any kind of in between the carbon and the hemodialyzer
So we grabbed all of the samples. We just need to kind of figure out funding and paying for it. So we have all the samples. I've got them all in the freezer.
Carolyn, you did some samples somehow.
We did pre and post only. And we charged the owner. The owner wanted to know as well. So we charged the owner for the pre and the post.
I love an owner when they want to know.
She had Trupanion as well, and we were well under the estimate. We gave them an 8 to 10 estimate. The dog went home for just under 5.
Wow. So, I mean, philosophically, medically, I know some of those, you know, pre-carbon, post-carbon, pre-filter, post-filter, like those numbers are a little bit for us and for research and that. But I mean, I think the pre and post and maybe even some samples in the middle are part of knowing how our treatment is going and benefit the patient. So I don't have a problem with them chipping in for some of those costs. I think there's a balance point in there somewhere. That's part of it.
Yeah. We did 20 full blood volumes on him, and we did samples every 5 blood volumes. So, and the referring veterinarian, they after they called us, we had them give him a dose of lipids, and he started to wake up a little bit with the lipids. They were able to extubate him about an hour after giving him lipids. So we have a pre-lipid sample from them, but it sat on the gel separator for quite some time, so I'm not positive how valid that sample's going to be. But we have post-lipids. We have a post-lipid sample from them that was probably about just as they were trying to extubate him the first time. So.
And was this an acute, like injectable overdose, or like got into
No. He unfortunately, the owner had an epileptic dog that apparently passed away about an hour and a half, a year and a half ago, and the owner, the owner was purging all the old medications, and I guess she got the bottle out, and the dog, it was literally 12-month-old Bernese Mountain Dog puppy, and he ate 6,000 milligrams of phenobarb.
Yikes.
So, yeah, it was a good dose. They had him for almost 20 hours. He had been intubated for about 15.
Okay.
Yeah.
Yeah, I wonder about, I mean, his phenobarb's got if I recall right, pretty wide volume of distribution. So
It's actually low. It's 0.6. It's
Oh, okay.
0.6 to 0.7.
I thought it was one of those ones that sometimes required a second treatment the following day as it rebounds out of the tissues, but maybe I'm misremembering.
Research we did said 0.6 to 0.7.
Okay, which is still total body water, which is still
Yeah.
everywhere, I guess.
Yeah. So no, he did great. He was a bit nutty yesterday. Enough so that we gave him a mic per kilo of dexmedetomidine to pull the dialysis catheter. But he had enough phenobarb left in him that he zonked out from it. Oh, Jeff showing you the video. This is directly post treatment.
Hey, buddy.
Yeah, if you give him a sec, he'll look in our dermatology room, and then he'll actually trot down the hallway. A little ataxic, but much
awake.
better. Yeah.
Awake and ataxic beats intubated and sleeping every day.
Yeah.
And did you guys just use one 300 mil column? Did you swap out at any point?
100 mil column. Never swapped it.
Wow, great.
Yeah. It did great.
What kind of catheter did you put in him?
I put a 13.5 French. I used the Medcom, their oval catheters. It's got a third lumen in the middle. They use it in people for CT scans for contrast, the administration of contrast through it. But I love the catheter. It gets absolutely beautiful flows. I've never had a problem with it. The lumens are side by side, and so they're a double D configuration. Yeah.
I do enjoy the MedComp catheters and the silicone catheters a lot. And I've got 2 cases going on right now. I've got one hemodialysis case in a small, actually they're both around the same size. She's around 10 kgs and then my TPE dog is around 11 kgs. And I do have, I've got the MedComp 11.5 French in the dialysis dog, just knowing that I was going to need that a little more long-term. And I went with the Mila 8 French in my TPE case because I knew I didn't need quite as robust flows, but and his jugular was just so hard to find. I ended up doing a cut down on him to get in there. I don't know if you're experiencing this or not, but my IMHA dogs, typically by the time they're coming to me unless they're like coming in the door for it, they're often quite edematous and really jiggly in the neck, even more so. This is a little pug that's already a little bit flubby, but yeah, it was just as I was doing the cut down 2 days ago to get in there. I was like, you know what? I'm doing more cut downs on IMHA dogs than I am on others. And maybe that's just a my technique and not being able to hit that vessel as well, but just so jiggly in there.
We've had a few IMHAs this month, and they haven't been too bad. We had one that was profoundly thrombocytopenic. The platelet count was 18,000. When it comes to catheters, the 13.5 French is the only catheter we have it's the only size they make that's that oval catheter. Otherwise, yeah, I try and use silicone catheters.
Maybe I'll check that one out. I've got, the MedComp, again, I prefer the MedComps all around, but I've got their 11.5 in both a 20 and a 24 centimeter, and then my 14.5, 14 French. I haven't seen that 13.5 one, but maybe it's time to expand
I will give you fair warning. It's a 13.5. It's the CT Trio catheter that they make. Unfortunately, so far, I've never had one of our residents be able to place one. They don't go in smoothly. The tip of them is a little bit odd, and so it's a little hard to get it kind of into the right track. And actually, so far, the only person that's been able to place them at our hospital is me. But once we get them in, we love them. So we do keep them kind of for our lepto, our IHD patients and the TPE that need repeated treatments. But they are a bit difficult to place. So that's my one warning. They don't go into the track very easily.
Hey, Jethro, aren't those MedComps, aren't they quite a bit more expensive than some of the others?
Quite a bit. Yeah, I mean the Milas, I think our cost to the clients is under $200, and with the hospital markup on the MedComp, it's over $4, or right around.
My feeling is you can get a Mila for like $50-$60 when the MedComps are typically in the 200 to 300 range.
Yeah, but I mean, I don't know if I can do it. For me, it's worth that trade-off, financially speaking. If it's going to be in there for any length of time, like the short-term guys, that are single, hemoperfusions and even the IMHA dog, I'll skimp a little bit on the silicone, but I'm always looking at that insertion site and knowing that those Milas like to kink right there on me anyway. The polyurethane ones, I should say. And I'm not trying to slag Mila. I shouldn't maybe use brand names, but the polyurethane based catheter, I guess is more what I'm getting at.
I agree, but I feel like it really depends on your case. Just like you said, if I'm starting an AKI dog, there's no way I'm going to go for polyurethane because I know I'm going to be there like 1 week, 2 weeks, 3 weeks. And there's no way that polyurethane is going to stay that long functional. But if you get a toxicity, I don't see any rationale to use a $300 catheter for one treatment. And also, just like speaking of ease of use and placement, I mean, the polyurethane are actually a little stiffer, and I feel like they're easier to drive in the jugular because of that stiffness. That sometime when you get like even my absolute like I love that catheter, the 11.5 Medcomp is really nice, but it's also all jiggly. And you can tell like sometimes I've got people that are not used to placing those catheters too much. They're trying to take it there and push it in. You really need to grab it like 2 centimeters from the skin to have good pushability because they're not stiff. Whereas the polyurethane is a little bit more user-friendly on placement, I think.
Well, I think just before you signed on, I was confessing to Carolyn that I had to do a cut down on this IMHA dog with the polyurethane catheter, so I couldn't get it in. But that was more of a me. He was super jiggly and edematous, and I think I was saying our medicine folks do a pretty good job not overloading these guys, but they do because they do get blood products and they're on. And this is actually maybe a good question for this group. There's the notion, on the human side, hemoglobin, myoglobinuria, and the risk of AKI seems to be a pretty significant one. And I know there's a few papers from a little bit back ago that maybe said it's not so much of an issue in dogs. But a lot of our teams are like, well, I got to have them on high rates of fluids just to protect them from an AKI from all the breakdown products, and so they often do get a little bit heavy and a little bit edematous that way. I don't know, Cedric, do you guys or Carolyn, like, do you guys have that fear of that AKI from all of those breakdown products?
I mean, I don't think there's any robust literature on that, at least on the veterinary side. However, like when I was back in France, I was seeing my good share of Babesia. And typically, those dogs would go into AKI, especially when they were very hemolytic and the urine was like brown to black. So I do think pigmenturia is causing AKI. The question is, are we actually improving the outcome by diluting it? Because it's not always like, for example, we know for aminoglycoside that you would rather like give one shot of the higher dose once a day because you're going to actually saturate those transporters and you're not going to have so much intake in the tubular cell than if you're doing the same dose split twice a day. You actually have more intake and more nephrotoxicity. So diluting is not always making things better. So I think I'm not sure we got a good take on that, but obviously I feel like those that are the most hemolytic intravascular are the most at risk of AKI, probably.
I don't know. Damon, Cedric, I was able to hear you were kind of coming in and out there. So I got the message, but the mic was a little bit off. I don't know if that's my connection or Jeff. Did you have that same
thing?
Yeah.
Yeah, I
No.
hear you.
All right. Now we got DJ Jazzy Cedric here.
I feel like we treated an extremely bad IMHA earlier this month, and but I think recently we're seeing more things like trolley than we are actually seeing AKIs. It's been at least a year, I think, since we had an IMHA last year that had a mild AKI, but we've had a couple in the last few months that have developed like trolley with their transfusions. And then now that vet starch is gone, we're using a lot more plasma. So I think yeah, we treated 3 dogs with TPE 3 weeks ago, and we lost one of the IMHAs, and it was probably trolley. She had really, really bad trolley.
Carolyn, I think that hits on my point a little bit. I wonder, like, I'm not questioning that it was trolley necessarily. I think I have seen more taco rather than trolley, and for I don't want to throw a bunch of acronyms at folks, but transfusion associated circulatory overload. I mean, I guess it's hard. How do you distinguish those two, when you're, faced with a dog in respiratory distress with infiltrates? I guess you can look at left atrium and see where volume status might be. But that I think comes back to, I've seen that happen so many times. These dogs get these, large volumes of red blood cells, which are going to stay and fill the IV space. And then they're chased with these crystalloids to try and dilute out, all of those potential nephrotoxins and prevent the AKI. And I do wonder and maybe it's a combination, and you can't label them all the same, but I think there is a circulatory overload issue in some of those guys, as well as the potential for the transfusion related acute lung injury. Plus, you've got your risk of your thromboembolic events all in there as well. So I don't know. I think it's a bit of a mixed bag, but I do worry about the volume that these dogs get a lot of times. Just let me pull up the guy that I've got here today. So I think you brought up
I think, can you hear me better now?
yeah, that's great.
I think actually that's where also, I mean, Cargill used to do that in our patients, especially the small ones where we would have to use some product for blood prime, and it would always remain like some in the bag. And at the beginning, like that dog would probably receive those packed red blood cells after treatment within the ICU, adding to the volume. And we actually started to use the packed red blood cells resuspended in plasma as a replacement fluid. Because when you do that, you are able to give a fair amount of red blood cells without giving any volume, because you're pulling out the plasma while you're giving those red blood cells, right? So you don't have that overload problem. And the other thing is actually the impact on your PCV is way better for the same amount of packed red blood cells you're using, because you're removing plasma and you're replacing that with a 50-60% PCV solution. So that's sometimes a way to get around that. If you're like a patient that is already overloaded, but you still want to transfuse, you might be able actually to transfuse during your treatment by using your packed red blood cells as replacement. That's a workaround.
Yeah, you're speaking to the choir over here. I love that that effect. I tell everybody about that, Cedric. And here's the crit line with that, using a pack cell as replacement here at the end of this treatment yesterday, actually. I think the challenge, less so around the extracorporeal part, because again, yeah, I mean, you make such an amazing point there. It's the leading up to that, the first couple of days in hospital as they're getting their transfusions and pack cells and their crystalloids and everything else. I think that's where I've seen more of the morbidity and some of that volume overload and edema that forms. And then, obviously, then we got into the taco trolley discussion too. But yeah, I tried. This one didn't climb as robustly as I thought it was going to yesterday. But he was at about 19%. And we just did, this is an 11 kg dog. And I think this was about 80 mils of packed red cells as replacement just at the end of this TPE session, and brought him from that 19 up to almost 26, in the blink of an eye. And such a more robust increase because we had removed plasma and replaced it with red cells, like you said. I love that phenomenon. It's such a nice thing to see in real time. And then and I could go back a couple steps here. This is a dog that's, let me get back out of here. This is a dog that's we actually, and I don't have it on one of the slides, after he got 2 transfusions. This is an 8-year-old male castrated pug, non-associative IMHA, had received 2 packed red blood cell transfusions over the course of 2 or 3 days. And we were talking about TPE even after the first day there. Our medicine team is really on the ball with this. And I had a little bit of a scheduling issue, so it took me till day 3 of his hospitalization to be able to do our first treatment. But he's one of those dogs that was not, they cross-matched him to 10 different units at this point in time before we did TPE, and non-compatible with all of them at that point, which, you know, is always one of those challenges. So when we did the first TPE session, for the replacement that we used some red cells at the end of it there, we were left with that challenge of, well, he didn't cross-match to anything. And we know that's, the disease and his body's on fire, and I wasn't expecting him to be compatible on a cross-match test anyway, but how do you interpret that? So we picked we closed our eyes and threw a dart at one of the units, and we used that for our replacement, and he held on to it. So I'm just waiting today to see if they were going to cross-match him. We've done 2 sessions with him for a total of 2.5 plasma volume exchange, I think, over that time. Actually, almost 3, because we did a pretty robust, I think we did 1.7 plasma volumes yesterday. And so I'm excited to see if he's now compatible with some of the other units. I'm a little more, comfortable living in that world. I know the folks in our hospital get really scared and appropriately so. And we're worried about what they were going to do to get some red cells in this dog if he wasn't compatible with anybody. Let me just get out of this guy here for a second. So let me see. Let me get to him here. I had a question for, I don't have any pictures of him here. I was running this session with him, and yeah, I apologize. I don't have any good pictures of the treatment in there. And I was running him with plasma. He was a small enough dog, and we were targeting a 1.5 plasma volumes exchanged for him. And I ran into TMP issues, which is something I haven't had a problem with. I keep my filtration fraction, fairly around 20%. And we were running at 20% with him. And we had rising TMP alarms. And ultimately, then it stopped the treatments. And I took out the crit line that was, before the filter, and really troubleshot and even dropped down my filtration fraction. I was down around 10%, which was going to be a really slow treatment. Sorry, this is on the Prismax using a TP 2000 set. And I couldn't overcome the TMP pressures. And it started, his anticoagulation status was great, which was another one of my, troubleshooting mechanisms. I dropped my filtration fraction way down. And it was the first time, and I've treated some really bad IMHAs, and I know there's a whole lot of debris floating around and breakdown products. So I was attributing it to either one, my Prismax having a bad day, a problem with my set, or just that there was so much debris floating around that it was really clogging up those fenestrations, those pores on my membrane. And I ultimately ended up having to trade out the set halfway through the treatment to see if I could overcome it that way. And my second set had some similar issues, but we were able to limp through the remainder of a 1.4 plasma volume exchange without that set failing. So I don't know, Cedric, you've probably done a bunch on the membrane-based TPE set. Have you come across that with your bad IMHAs?
Actually, not using the Prismax that much for TPE. I mean, I've got the Optia, and the Optia is so much better. I feel like it's really, really easy treatments without too much complications. I don't have that much experience on the TPE 2000. I probably did like a handful of treatment on it.
Okay.
And then I went back just when we got the Prismax, so I could know like how to do TP on the Prismax. And then I went back to the Optia because I can set that up at 2 a.m. like eyes closed and let it run without any problem.
Carolyn, I saw you unmuted there. Have you guys come across this?
So I'm gonna jump on Cedric's bandwagon a little bit because we just got the Amicus and we just started using it in the last month and a half, and oh dear Lord, do I love it. It sets up so beautifully, and it's kind of like set it and forget it. But that being said, we have previously done a ton of our IMHAs on the Prismaflex with the TPE 2000. The one thing that we used to do, we've kind of stopped doing it in the last little while because we're like, it's kind of useless. We would tag these guys a lot, and on their tag, they are really, really hot. Like their tags are massively hypercoagulable. And I think what we're thinking and finding is they've probably got just a ton of circulating fibrin, and that is clogging the pores on the membrane filters. Because we've had a few really hot IMHAs. We had one hot IMHAs that we ran through 3 filters, and we were able to barely pull out between the 3 filters one full plasma exchange, and he just kept clogging the pores. And then we're like, we give up. We'll just see if maybe some of that circulating fibrin will get removed from him, and then we'll restart the next day. And then he stopped agglutinating, and he was better, so we never had to do him again, which was great. But I think there's a ton of floating debris. I think they've got a ton of, they're so hypercoagulable. They have a lot of fibrin circulating, and that clogs those pores so quickly. One of the ways that we found that works, that sometimes helps us a little, is we usually start with a pretty low filtration fraction, sometimes even just 9 or 10%, so that we're not pulling quite as aggressively. Because when we start with our filtration fraction over like 15 or 16%, we were finding that we would get that clogging a lot faster, because I think we were just trying to pull a little bit too fast. So we start with a slightly lower filtration fraction, and then over the course of the treatment, if we're doing well and the TMP stays pretty steady, we will increase it. The other time that I noticed that clogging occurs, when I'm not sure what the Prismax does, but our Prismaflex does a self-test. And when it does that self-test, it pushes and pulls against the filter. And I think that's when it clogs it, because I'll be getting TMPs that are like literally under 20, and it'll go through the self-test, and you'll watch the TMP fluctuate a little bit. And right after the self-test is done, usually within 2 to 3 minutes, that's when the TMP will all of a sudden start climbing rapidly. Because I think that self-testing and pushing and pulling against the membrane is when it clogs those pores. But that's just what I feel like I've seen based on experience. So sometimes if I can catch it, I'll actually pause the self-test.
And are you using heparin or citrate in these patients?
We use heparin.
Because I wonder if that could be one of the differences too. I mean, I feel like, just like you said, those IMHA, they're kind of like tricky because they're really clotty. And I feel like probably citrate does a better job at keeping the system patent than heparin will, for some reason. But I wonder if you would have less problems on the Prismax using original citrate than heparin.
Yeah, no, that's all good points. This is just, this one was, man, this was a long night with this dog, going through that. So Carolyn, as much as misery loves company, I'm glad to hear of that case that you described where you went through 3 sets before kind of calling it a day on that session. So I was pointing the finger at myself, figuring I had set something up, inappropriately, and I had done a little bit of maneuvering with the plumbing. I was trying out a couple of things. So I'm like, something I did there. But yeah, no, what you described there makes a lot of sense. And our second set fared a little bit better on that first treatment. And then we did our second treatment yesterday, and I had it a few times, saw that TMP rising and got that that warning on it. I wonder if that was during the self-test. And maybe that's because it was riding fine, and then out of nowhere it would start climbing, which it seemed just a little bit out of the scheme of things. This dog had been on rivaroxaban and clopidogrel for several days because he originally presented with neurologic signs that they thought might be thromboembolic in nature. And we were using a heparin-based anticoagulation strategy, but he was also only getting only getting plasma as replacement. So he was seeing a pretty decent citrate load as well, going through that circuit. But some of that, obviously is probably bound to keeping the plasma from being keeping it anticoagulated. So that might not actually be helping. So yeah, I might have to look in these really bad guys at either changing over to getting a centrifugal unit, and or thinking about regional citrate instead. So good things to chew on here, and it makes me feel better to hear that maybe it wasn't my plumbing monkeying around, and maybe it was that circulating fibrin like you described.
Yeah, but I feel like if you try centrifugal TP, you're never coming back.
Well, I'll tell you, I've got I forget, Cedric, if when I saw you last, if I shared this or not, but there's Sloan Kettering down in New York City has 2 retired Optias that they're donating. They donated one to AMC, and I just have to drive down and get mine. So I got to take a 5-hour trip down to the Bronx, or no, sorry, it's in Yonkers, and figure out how I'm gonna transport it back up to Ithaca here, and then I'll be in the club with you guys at some point soon here. By the looks of
Gotta be cautious though, because right now, Terum Obesity has sent mails to say that they will not support older Optias. And I know that I think Erika was in that situation at Penn. They sent it to Davis. Mine is probably going to be in the same situation where we have a perfectly functioning unit with no problem, but they're asking us to replace it because they're not going to support it anymore, which is like bonkers to me, because basically they're asking you to buy a brand new machine where you have a perfectly functioning machine that they just don't want to service anymore.
Yeah, that's going to be, I mean, the trade-off there, because it is older, it just went through its PM and passed fine. They kind of said, and again, it's, passed on through a couple of hands now, so it's not going to be probably eligible for any servicing, whether they were phasing out or not. But if I can get a year out of it until I build up enough cachet to purchase a new one, I'm at least saving the out-of-pocket cost up front.
Yeah, no, I mean, if it's
But
donated, it's no brainer anyway. But I'm just like, if you had to purchase it even for a good price, you'd have to factor that in, the fact that you may not be able to use it past like a year or so. And I don't have all the details of which one are going to be phased out and which one are not. I think it depends on how old they are, and it's problem with like getting the parts or something like that. But it's pretty annoying.
yeah, a little bit of a, well, I'm sure they're making plenty of money on their own, but it sometimes feels like a little bit of a scam there. Like, nope, you got to buy a new one from us. Carolyn, how long have you guys had the Amicus? Just recent?
It's very recent. It's been in the hospital since June. And so yeah, and we just started making use of it in the last like 2 months. So yeah. It was luckily there was a donor, so they donated the money for the Amicus. And oh yeah, no, that's right, I took delivery of it the week after Renal Week, but we didn't get training until June.
No.
But yeah, literally we were talking to the Fresenius Cavi people at Renal Week, and they were like, if we need, they told us that they needed to get it off the delivery dock by the 31st. And so we took delivery of it literally on the 30th of March. And it sat on our delivery dock for a couple of months. Yeah, but I am really, really liking it. And we just got the spool for the MNC collection. So they're going to come out in a couple of weeks and go over MNC collection with us.
I didn't get that. The internet isn't reachable.
Yeah, for the MNC procedures are really fun to do.
How many TPE treatments have you done on it so far, Carolyn?
We've done, well, 3 weeks ago, we had 3 patients at the same time on it. Basically, we're just kind of cycling through patients every day on it. We've done probably about a dozen sessions on it now in the last 2 months. So like Cedric says, it sets up really easily. It just kind of, I mean, I always used to think the Prismax system was really nice because, you know, you just put your kid on it. It tells you everything to do. This is even kind of easier to a degree. It just sets up so easily. and you know, it just kind of runs itself.
Yeah, what I really like on the Optia 2 is the automatic management of the original citrate. And I wish I could get the same on an HD on a Prismax, but
yeah, it's just you kind of set it, and you know, we set the QB, and then it just kind of does its thing all on its own. We just monitor the patient. Usually we do check an ionized calcium a couple of times just to make sure that we're doing okay. But otherwise, yeah, it pretty much kind of runs itself. And it's really nice because it does the return. You don't have to like unhook the access, you know, and worry about all of that. You just kind of go, yes, reinfusion, hit yes, and it just it reinfuses the access side. It tells you to clamp the access, and then it reinfuses the return side, and then you just unhook it, pull it off the machine, and throw it away. You're done.
Have you found, and I don't know, Cedric, you might comment on this too. I haven't used one, but I think in a couple of these sessions or in maybe other discussions, there's been a few folks that have found some clotting in that one segment, I think before the citrate joins the circuit there between the patient's catheter and the, you know, just where it attaches to the line. Have you found you needed to heparinize these guys in addition to the regional citrate?
So I feel like it really depends on the size of the dog, but like for smaller patient, less than 10 kg, I would say, it turns out what with the whole citrate management, you sometimes end up with a blood flow of like 5 to 10 mils per minute. So it's super slow. And these dogs, just like Caroline said, are like pretty clotty. And so sometimes we would see clotting in that segment of the circuit, which is pretty small, but if you're running that slow, it still spends some time in there. So I tend, on very small patient, I tend to heparinize them at the same time. And the way I see it is just like, I've got the citrate for the machine, and I'm just giving a little bit of heparin for that like first segment of a circuit. So I'm usually working with an ACT around like 160-ish. Because I mean, I don't really need them to be super heparinized because it's really for that little segment, and I don't want to have any risk of bleeding. So, but I give a tiny bit of heparin for sure, and especially I prime them too, because I've had a couple cases where we would start the treatment, and for some reason we would get a clot in the very first filter in the cartridge. At the very beginning of a treatment, just like if we had a bunch of clots just coming out of the patient in the filter. So I prime them, start my treatment. I keep a pretty low ACT. I feel like if you get a bigger patient when you're running, I don't know, like 30, 50 mils a minute, I mean, then you're fine. It's like it flows fast enough that the blood is not spending that much time in there. where we had also a lot of clotting at the beginning is when we were like adding the crit line. Because then we'd have like to have a connector between a lure connector between the catheter and the crit line, and then another like adapter like from DIN to lure to go to the circuit. And then instead of having that piece of tubing that is not citrated, you end up like with that piece of tubing. And you add the crit line, which is like a very clotty part of circuit too. So that would be the way. But Dr. Cagiel found a workaround on that to put the crit line in the citrated part of the circuit, which I will not advertise too much because I don't think it's a Terum obesity approved procedure.
I think I've heard him describe that.
Yeah.
Cutting, sealing, resealing.
No, not sealing, just like shoving into a three-way stopcock. Like there's no sealing at all. That's my problem. I'm just waiting for that circuit to burst in the middle of the treatment.
Yeah.
But anyway.
Well, I'm excited to expand our arsenal to include centrifugal based application too. We'll get there. Let's see what else I had on this guy. Yeah, I was gonna bring. I didn't get a chance to put as many of these pictures together on here. I've got an update on one of my other long-term dialysis patients, but rather than me talk about stuff, I don't know. I see, Ray. I don't know where you're at and what you're doing. Do you have? Are you in an active extracorporeal unit now, or do you have any cases that have been going on, or any questions that have come up?
Hi, I'm at Friendship Hospital for Animals as a resident right now.
Oh, you guys are really busy then.
Yeah. But I've been out sick on research this week, so I don't have any cases to share.
All right. Well, I hope you're feeling better. Inga, I see you on there as well. Do you have any cases recently or any questions that have come up around stuff or good discussion points for us? Maybe they're in name alone. Andre, how about you guys? I guess, is he still with you, Cedric?
Sorry, I was distracted. What did you say?
Oh no. Where's is Andres still with you these days?
Yeah.
Oh, okay.
Yeah. Yeah, still with us for like probably over a year or so.
Nice. Well, let me bring up my friend Kaz here. So I think this will be a little bit of a cathartic story here if I can find my pictures of him here. We've had a couple of long-term patients here in the last year that have been really rewarding for us. And I'll bring up Kaz here and I'll just give you guys a quick update. It's a little bit of a tough update, but let me share this one. There he is. Well, here's Kaz. Kaz was a 3-year-old. Or he still is. Well, now he's 4.5, I think. Male castrated border collie, and he came to us 1.5 years ago. And I'm going to skip through some of this stuff, but he was an AKI secondary to his dad. Is an active. He's got, I think he tells me, 55 tractors and ethylene glycol all over the place. And so we got down to the diagnosis of ethylene glycol induced AKI for him. And we treated him. This was an owner that, and I know a lot of you guys have had these really committed, outrageously committed owners. This guy would drive 5 hours one way to come and see us every third day for treatment for CAS, and then drive 5 hours back again. And how he afforded the treatments, which became substantial. At that point, we only had our CRT platform, so we were doing PIRT, combined hemodiafiltration with CAS over this 3 months that we treated them. We more recently, as we expanded and brought in our IHD platform, our more recent 3-month chronic treatment dog or AKI chronic kidney ended up being a chronic disease dog that we're doing. Much more cost effective on the IHD platform, as we all know. But anyway, this guy, very committed to this dog, and this dog was amazing. This dog actually came and lived with me for a little bit when Dad was out of town and couldn't bring him for treatments, but he was the one who was the active on his farm here. Here he is with his dialysis catheter in, going out and herding the cattle. There he goes in his dialysis harness and catheter, which I felt two ways about. He was living his life, but my concern over that catheter was enormous. But incredibly, the catheter, it wasn't until maybe 3 months in, I think he was starting to develop a fibrin sheath around it, and he had the 14 French Medcom catheter in. And we did have to back it out a little bit to find a sweet spot for flows. But he actually, this was him when he came to stay with me. And again, I love the quality of life in between treatments. He went 3.5 months and 100 days here. You can see on here, this was his last treatment here, day 95. And eventually he plateaued out into the high 4s with his creatinine, eating great, doing great. And so he graduated after 32 treatments over 3 months. Just a really amazing story, and just I mean, there were times along the way when we were just seeing very mild improvement in his rebounds, and I was just worried for how much work was going into this from the owner and from our team as well, that he wasn't going to ever graduate, and he did. That dialysis catheter lived in him for 106 days, which is almost a record. This was it at the time we were pulling it. Still a nice clean insertion site. Never had any obvious infection or any other complications with it. But let me get past to here. CAS is now a year, almost October 17th is when we pulled his dialysis catheter, and he's now a year out from that. Unfortunately, over the last 2 months, we've seen a rising creatinine and BUN for that matter. He's been living a great life. He was on phosphate binders, and for a while he was on a home-cooked diet because his potassium and phosphorus were creeping up. But he had been living great quality of life in that year. And about a month, maybe 2 months ago now, we started to see his creatinine go from the 5s, where he kind of sitting as his baseline for that year, creeping up into the 6s and 7s. We re-ultrasounded him. We tested for everything all over again. We cultured. We put him on antimicrobials in case of a hidden pyelonephritis that we couldn't grow anything. His ultrasound of his kidneys, they looked fairly chronic without any obvious acute component, but we were still holding out hope that there was some kind of acute on chronic causing his creatinine to rise. But he is now with a creatinine, I think his last one was 11 and his BUN was around 150. He has good days and bad days. He eats sometimes he doesn't eat. Dad does sub-Qs at home. He's still on antimicrobials, just again on the hope that maybe there's a hidden pyelo in there that we ultrasounded him thinking we could try and get a pilocentesis, but he really didn't have any renal pelvis dilation of note for us to sample, so we didn't do that. And yeah, I mean, Dad sends me pictures every day. The one this morning was him playing fetch with a stick, with a creatinine of 11. And I think that's just a testament to the strength and the spirit of this dog. But I think we're into what we've decided is somewhat of a palliative time frame for him. We talked about reinitiating dialysis treatment for him, and Dad's just not able to commit to that and doesn't feel like that's the right decision for him. So after 3 months of treatments, and graduating, and now a year of great quality of life, it seems like we've hit that 1 year point where we're getting closer to maybe an end point here than not. But I think it's just nice to kind of come full circle and share that an ethylene glycol dog can indeed recover enough kidney function to live without dialysis, if given some time. I don't know if he beat the odds. We've heard stories of other dogs that I think Calgill has treated for long term and have gotten off dialysis as well. And then we see this 1 year term before I think we've just advanced our chronic disease state. And so that's where we are with Kaz. And for just anybody who heard some of his story last year when I shared it, I figured I'd bring that full circle here and see if anybody else has gone through something like this with, those graduating dogs that then do end up having, and we know that, their chronic disease is going to catch up with them at some points. And it seems like his is doing that. So that's where Kaz is at these days.
How much did you recover? Like, where did his creatinine go? Like the lowest point?
The lowest points was 4.2, I think, if
Yeah.
got that right. And then he, that was when we pulled his catheter. Let me get back to that one. Sorry, 4.3. This was the best he ever was. He ended up 4.5 in here, and then like within a month he was living in the low 5s.
Okay. Yes, I mean, a year is actually pretty impressive, right?
Yeah, I think so. And Dad, every time I chat with him, he's like, we knew this, was eventuality, and every day's been a gift. So I think just a really nice testament to getting this dog a great 3 months of dialysis, and then a year after graduating of great quality of life. And again, still some great days he's having, which is incredible with a creatinine in double digits and BUN that high that he's actually kicking along here. So
yeah, I've had a patient spending almost like 10 months with a creatinine more than 10 before he actually like the bucket. And like I kept telling these people that we were near the end, and the dog was like, no, not done.
That's well, I'll share that with Dad. I mean, he's just going day by day, week to week,
Yeah.
waiting on him. And again, some good days, some days he doesn't eat or drink very well, and the next day he rebounds and he's feeling a little bit better and does a little sub-Q fluids and
Yeah, my patient was more of a juvenile chronic kidney disease, and I feel like those do exceptionally well with high values. But this one was really like a crazy case. Like he lasted way longer than I would have expected in any way. At the end, his ionized calcium was 0.5 on calcium supplementation and calcitriol, and he was still doing fine, which is crazy to me. But yeah, like so almost a year like that.
Right. Well, we've almost got through an hour here talking about TPE and Prismax and those fibrin clots and fragments that drove me crazy. Carolyn, hey, question for you on that one is the folks that I'm on that case where you went through those 3 sets on that one treatment. I'm going back and forth. I'm going to approach our hospital team about discounting / refunding at least one of those sets. I mean, it's the patient's disease that really contributes to it. But I think in fairness, these folks don't have major cost constraints, but I still think I'm gonna see if we can discount out that one set. Did you guys account for that in your billing practice with that case?
We do. In that dog's case, I was like, the first one, I was like, it was like, did we do something wrong? But I had seen this before. We'd had cases, a few cases prior to this that we'd had it done before. We did charge the owner for 2 of the sets because we knew it was the dog's disease process and not necessarily us. The third time we were like, after he clotted 2, we were like, do we just give up or do we just try one more time? And we were like, our thinking was that we had hopefully removed enough of the debris and the circulating fibrin that maybe we could get through a third set. I had never not been able. That was the first dog I'd gone through 3 sets with. I'd gone through a couple of dogs where we'd burned 1 and then been able to kind of work through a second set. This was the first dog that we clotted like 3 really fairly quickly, relatively speaking. So we did charge them for 2 of them, and we charged the third one, and then the hospital wrote it off basically. In previous sessions, it's kind of been, you know, and I know this is, again, this is one of those things where like, oh, these people have insurance for the dog, so we charge them for both the sets. Versus, you know, these people are paying this out of pocket. We'll just write off one of the sets as kind of, you know, what happens with these dogs sometimes. So it's always kind of been a case by case basis. But yeah, it's a hard thing because it's like, did we remove enough fibrin and circulating crap to get through with a second circuit? And usually I feel like we do, but yeah, that one dog. 3 circuits later, we're like, we're done.
Yeah, I was, man, there was a lot of, I had one of my first year residents, spending time with us for that case. And it was the first case that she'd spent some time with us on. It was not the, most amazing experience for her in terms of me being able to actually talk through what was going on, because we were just dealing with all those hiccups all the way through it. But, well, that's good to hear that, yeah, it wasn't necessarily all of my end of things, that there's, you've seen this before. Cool. All right. Well, with that, looks like we're through the hour here. Thanks everybody for chiming in. Jeff for sharing that video of the phenobarb dog that Tufts did, and Cedric for jumping in and telling us about the your Optia, and Carolyn for contributing all that stuff about the TP 2000 set. That makes me feel a lot better about this case. We're going to treat him again tomorrow, I think. I'm just waiting on his CBC to come back here today. His bilirubin is still in the 30s. It was in the 50s before the first treatment. But his CRP is coming down. I've been tracking CRPs a lot in these guys, and he came from around 100 to 60, and today he's down to 24. So hopefully we're moving in the right direction. I'll just see if he's agglutinating today or not. Hopefully not. And yeah, we'll get to it. So with that, close this out here and thank everybody for sharing, and good to see everybody's faces and hear your voices and experiences and stories, and see you guys in a couple weeks.
Thanks, Jethro.
Yeah.
See you guys.